All of you are welcome in today's session. So today's session is all about the adrenal gland disorders. In adrenal gland disorders, so first we'll start with the basic anatomy and physiology of adrenal gland. The adrenal gland is mainly located above the kidneys. By the name itself is telling above the renal, means ADRENL, above the renal. That means above the kidneys. And the important function of adrenal gland is that it synthesizes some hormones. So there are two parts of adrenal gland: the outer cortex and inner medulla. Outer cortex is having three zones: zona glomerulosa, fasciculata, and reticularis. In zona glomerulosa, mineralocorticoids are synthesized. In fasciculata, glucocorticoids, and in reticularis, androgens are synthesized. The most important mineralocorticoid in human body is aldosterone, and the most important glucocorticoid in human body is cortisol. You should remember these two very well, okay? And in androgens, dihydroepiandrosterone is synthesized, which is a precursor of progesterone. Testosterone is responsible for development of pubic hair, axillary hair, and is responsible for libido also. So what is the main function of cortisol? So cortisol is a stress hormone. So like in every stress condition, the cortisol is released in a fight and flight response. So cortisol is an anti-inflammatory. Also, it regulates the blood pressure. It is responsible for insulin resistance, protein catabolism, and immune response. So whenever the cortisol levels are high, the patient will be prone to develop diabetes because of insulin resistance. What is the function of aldosterone? Aldosterone is responsible for sodium and water retention, so it will cause hypertension. And in adrenal medulla, the catecholamines are synthesized, that are epinephrine and norepinephrine. In case there is a tumor in adrenal medulla, so the name of the tumor is pheochromocytoma, the epinephrine and norepinephrine will be increased. So the patient will have symptoms such as flushing of face and increased heart rate, increased blood pressure, headache, palpitations, and patient will complain mainly of a impending doom. Okay, the patient will complain mainly of like impending doom. He will have faintness and increased blood pressure and all. Okay, so these are the basic things you should remember in adrenal gland. And now we'll proceed to the first disease, that is primary hyperaldosteronism, which is also known as Conn syndrome. So what happens in primary hyperaldosteronism? The name itself is telling primary hyperaldosteronism, means there is no secondary cause of hyperaldosteronism. It is primarily due to adrenal gland disorders. So the causes are adrenal hyperplasia, the most common, adrenal adenoma, and adrenal carcinoma. So what happens when the adrenal hyperplasia occurs? So there is increased number of cells. So aldosterone synthesis will be increased, and this aldosterone will cause what? Sodium retention, and along with sodium retention, the potassium and hydrogen ions are excreted. So what is the condition the patient will have? Due to sodium retention, water will also be reabsorbed. Okay, so the patient will have hypertension, and potassium and hydrogen ions are excreted. So hydrogen ion excretion will cause metabolic alkalosis. So these are the clinical features of primary hyperaldosteronism. Like the patient will have hypertension, reduced potassium. So the normal value you should be aware, that is 3.5 to 5.5 millimoles. So the patient will have less than 3.5 millimoles potassium levels. So it will cause muscle weakness, and due to hydrogen ion excretion, the alkalosis will occur. So what are the investigations to confirm whether the patient is having primary hyperaldosteronism or not? See, first we have to rule out whether this hypertension the patient is having is due to primary hyperaldosteronism or due to secondary hyperaldosteronism. The most important cause of secondary hyperaldosteronism is renal artery stenosis. Okay, what renal artery stenosis? So in renal artery stenosis, there is secondary hyperaldosteronism, but the renin level is also increased in renal artery stenosis. But in case of primary hyperaldosteronism, there is no increase in the renin, so there is isolated increased serum aldosterone. So the investigation is renin aldosterone ratio, in which the serum aldosterone level will be increased and there will be low renin. Okay, for localization of the tumor, you can do HRCT or MRI. So what will be the management? First of all, the patient is having increased sodium retention, so we have to restrict the sodium intake. Okay, and there is increased aldosterone, so we have to give aldosterone antagonist, that is spironolactone. Spironolactone is given for many years for adrenal hyperplasia. And in case you are planning for surgery, then the treatment will be adrenalectomy, the surgery for adrenal adenoma. And there is another cause of hyperaldosteronism, that is glucocorticoid remediable hyperaldosteronism, and the treatment for that is dexamethasone. I will tell you about it as we move forward. Okay, so what happens in primary hyperaldosteronism? There is hypokalemia and hypertension. So there will be some differential diagnosis also for these conditions, like Conn syndrome is one of them, Cushing syndrome is one of them, Liddle syndrome is one of them, which is also known as pseudo hyperaldosteronism, 11 beta hydroxylase deficiency, and licorice excess. Okay, so now we have to diagnose. The patient is coming to us with the complaints of hypertension, and we do some electrolyte investigation and we say hypokalemia. So we should keep these 5 differential diagnoses in our mind, and to rule out these, so we have to see some specific findings of these conditions. Okay, but please remember, 21 hydroxylase deficiency does not cause hypertension. It is associated with precocious puberty in boys, and 11 beta hydroxylase deficiency is responsible for causing hypokalemia with hypertension. 21 hydroxylase deficiency does not cause hypertension, it causes precocious puberty in boys. Okay, so now you know how to diagnose Conn syndrome. You know, we will do the investigation renin aldosterone ratio. In that, we'll see aldosterone levels will be increased and renin will be low. Second thing, we should be aware about the Liddle syndrome. So what happens in Liddle syndrome is there is an inherited mutation of the collecting tubule sodium channel. So there will be increased sodium reabsorption. So there will be increased sodium reabsorption, but there will be no increase in the aldosterone. Okay, there will be increased sodium reabsorption, but there will be no increase in the aldosterone. Okay, so this isolated increased sodium reabsorption we can differentiate because there is decreased aldosterone, but in Conn syndrome there is also increased aldosterone. Okay, so in licorice excess, it is like a herbal remedy. The usually patients used to take in ancient times for gastric issues, or it is also used in candies and lozenges for cough. Now you can differentiate these two conditions with Conn syndromes. If the patient is coming with hypokalemia, with hypertension, so if the Liddle syndrome is a cause, then there will be a family history positive because it is an inherited condition. And in licorice, you can ask about the history, whether the patient has taken any herbal product or candy or lozenges. Okay, so we can easily differentiate Liddle syndrome, licorice excess, and Conn syndrome. Okay, in Liddle syndrome there is decreased renin, decreased aldosterone. All of the features are like that of primary hyperaldosteronism. Okay, so the main complaint is of increased blood pressure. And in Conn syndrome, we see that there is decreased renin, increased aldosterone, hypertension, hypokalemia, metabolic alkalosis. In renal artery stenosis, I told you about the secondary hyperaldosteronism before. In renal artery stenosis, the renin level will be increased. So we can easily differentiate renal artery stenosis with these syndromes. Okay, Conn syndrome, Liddle syndrome, or licorice excess. Okay, by checking the renin aldosterone ratio. So you know the basic mechanism. When there is reduced renal perfusion, there is sympathetic stimulation. The JG cells are stimulated, which secretes renin. Renin is responsible for conversion of angiotensin to angiotensin 1. Then angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, and which stimulates the aldosterone production. Okay, this aldosterone is responsible for causing hypertension. Okay, now I told you about glucocorticoid remediable hyperaldosteronism before. Here I told you about glucocorticoid remediable hyperaldosteronism. In case of management, we give dexamethasone. So what happens in glucocorticoid remediable hyperaldosteronism is that there is reduced cortisol. Okay, there is no cortisol production in our body, so there is no negative feedback on anterior pituitary. So there is no negative feedback on anterior pituitary, so there will be increased ACTH secretion. Okay, so this ACTH will stimulate adrenal gland melisoma glomerulosa, and there will be increased aldosterone. Let's start with the second disease, that is Cushing syndrome. But before starting the Cushing syndrome, we'll do a clinical question, that is a bodybuilder with azoospermia having a lab finding of low FSH and low LH but normal testosterone. Okay, a bodybuilder is having a no spermatogenesis, and but he's having a normal testosterone. So what will be the diagnosis? See, don't confuse this normal testosterone. If the bodybuilder is taking testosterone from outside, or either he's in the post-cycle therapy, or either he's taking selective estrogen receptor modulator SERMs. So these two can lead to increased testosterone or either normal testosterone levels. So, you know, the bodybuilder having low FSH and low LH is usually due to steroid-induced hypogonadism, and the treatment is SCG. Okay, let's see what is Cushing syndrome. Cushing syndrome means cortisol excess. So the cortisol level in our body is increased in Cushing syndrome. Most common cause of Cushing syndrome is exogenous. That is, the patient is taking iatrogenic corticosteroids, that he is taking exogenous steroids either for any treatment of a chronic disease or any dermatological conditions. So there will be a history of taking steroids from outside. So these steroids, exogenous steroids, mimic the action of cortisol in our body. So normally the cortisol level in our body will be low, but these steroids act on the receptors of this cortisol. They mimic the action of cortisol. So the clinical features will be of same as that of the increased cortisol level. But in reality, the serum cortisol level will be low because it is due to exogenous steroids that are mimicking the action of the cortisol. Okay, so there will be a history of abuse, but the ATM serum cortisol level will be low, and there will be clinical features of Cushing syndrome. That is a very important clinical feature is hyperglycemia and hypertension, that is due to sodium and water retention. And other clinical features are like fat deposit on face and back of the shoulders, that is there will be a central obesity, there will be a stria, purple stria, there will be increased chance of fractures in the body, and there will be buffalo hump, moon face. These are some common clinical features of Cushing syndrome. But the most common and the most important clinical feature is hyperglycemia and hypertension. Now, the endogenous cause of Cushing syndrome is Cushing disease. The most common cause of Cushing disease is ACTH secreting pituitary adenoma. So Cushing disease means there is a problem in pituitary gland. Okay, so there is a ACTH secreting pituitary adenoma, and this increased ACTH will stimulate the adrenal gland and lead to increased cortisol secretion. But because of this increased ACTH, there will be hyperpigmentation. So the question can come, what is the cause of hyperpigmentation in Cushing disease? It is due to ACTH excess in the body. Second thing is this ACTH can be either due to ectopic ACTH secretion, that the most common cause is small cell lung cancer and medullary thyroid cancer. So this increased ACTH will also cause hyperpigmentation. But please remember, cortisol levels are increased due to primary adrenal problems, okay, like adrenal tumor, either due to adrenal hyperplasia or adrenal tumors, adrenal carcinomas, adrenal adenomas. So this increased cortisol will cause negative feedback on ACTH and there will be no hyperpigmentation. I mean to say, if the cause of the increased cortisol is due to adrenal gland tumors, there will be no increased ACTH and there will be only increased cortisol level, so there will be no hyperpigmentation, okay? And please note that the corticosteroids inhibit the osteoblast activity in the body, so that will lead to steroid-induced osteoporosis. So please always keep in mind to give the bisphosphonate coverage with steroids, okay? So these bisphosphonates like alendronate, zoledronate should be given with steroids to prevent osteoporosis and increase risk of fractures, okay? Now, what is pseudo-Cushing's? Pseudo-Cushing's is due to physiological cortisol excess. It means that there is a physiological cause, like due to increased alcohol intake, either due to depression or increased obesity. So there will be increased cortisol level in our body, but it is not pathological. So the overnight dexamethasone suppression test can give false positive levels. That is, there will be high cortisol, but we can do an insulin stress test to differentiate. So it is an important question. Which test is done to differentiate Cushing's with pseudo-Cushing's? That is, insulin stress test is done to differentiate Cushing's with pseudo-Cushing's. Okay. Now you know what is Cushing disease. Cushing disease is if the problem is in the pituitary. That is, there is a pituitary tumor that is increasing the levels of ACTH, and this ACTH is leading to stimulation of the adrenal gland and producing increased cortisol. Okay. So what will be the treatment if the problem is in the pituitary gland? So we can do a transsphenoidal hypophyseectomy. If it fails, if the pituitary surgery fails, we can do laparoscopic adrenalectomy. We can remove the adrenal glands. And please note, usually the patients of the Cushing syndrome, they have increased blood pressure and they have uncontrolled diabetes also. They will have increased blood sugar levels and they will have increased blood pressure also. So they are usually medically unfit for the surgery. So we can give two drugs medically, like ketoconazole and metiropone. Ketoconazole is cytochrome P450 enzyme inhibitor that will inhibit the conversion of 11-deoxycortisol to cortisol. Okay, so there will be reduced levels of the cortisol and ultimately the blood pressure and sugar levels will drop. And metiropone inhibits the 11-beta hydroxylase that will also inhibit the production of cortisol. So ultimately there will be reduced blood pressure and sugar levels. Okay, now what is the investigation to diagnose Cushing syndrome? A basic investigation we know, that is overnight dexamethasone suppression test that is given at 9:10 p.m. and measured in the morning 9 a.m. Okay, so we start with the low dose dexamethasone, and if we give dexamethasone from outside, normally it will inhibit the cortisol production. Okay, so the cortisol level will be reduced, so it is normal. But in case low dose dexamethasone is not inhibiting the cortisol level is normal or increased, it is a Cushing syndrome. Now we have to diagnose whether the Cushing syndrome is due to Cushing disease, or it is due to ectopic ACTH excretion, or it is due to adrenal gland problem. So we will start by giving high dose dexamethasone, that is usually 8 mg. Please remember the dose, here it is 1 mg and here it is 8 mg. So we'll start by high dose dexamethasone. If the high dose dexamethasone will inhibit the cortisol production, it is a Cushing disease. So the cause is in the pituitary. Okay, but in case if this high dose dexamethasone will not inhibit the cortisol production in the body, so the cortisol level will be increased or normal, it can be due to two conditions. Either it is an adrenal gland tumor or there is ectopic ACTH excretion. So that we can see by measuring the ACTH values. If the ACTH level is low, then it is adrenal gland problem. If the ACTH level is high, it is an ectopic ACTH problem. Or else we can do a 24-hour urinary free cortisol, that is usually more than 250 millimoles. Okay, I have summarized this in simple point. Okay, in dexamethasone suppression test, if pituitary source is there, the cortisol level is suppressed. Okay, and if there is ectopic or adrenal cause, then there will be no change. There will be no change. There will be either normal or increased. Okay, we can do another investigation, that is corticotropic releasing hormone stimulation test, and in that, if there is a pituitary source, then cortisol rises. Okay, and if there is ectopic or adrenal source, there will be no change. Okay, here it is rise and here it is suppressed. Okay, please remember that in dexamethasone suppression test, if the cortisol level is suppressed, then it is a pituitary source, and in CRS stimulation test, if the cortisol level rises, then it is a pituitary source. Okay, and the most sensitive and specific is IPSS, that is inferior petrol sinus sampling, in which we take the venous blood for sampling and we measure the ACTH level, and if the ACTH level will be increased, it is a pituitary source. Otherwise, there will be an ectopic ACTH production. Okay. Now let's start with the Addison disease. So what happens in Addison disease is there is an autoimmune destruction of the adrenal gland. So any hormones that are synthesized in the adrenal gland, the levels of these hormones will be reduced. So the hormones are aldosterone will be reduced, cortisol level will be reduced, and sex hormones will be reduced. Okay. So because of this reduced aldosterone, there will be no sodium reabsorption and no water reabsorption. So what will it lead to? It will lead to hypotension, and there will be increased potassium levels. It will lead to hyperkalemia. So the clinical features are hypotension, hyponatremia, and hyperkalemia. So the symptom will be of lethargy. Okay, and the cortisol levels are also reduced. So decreased cortisol level will lead to hypoglycemia, because cortisol is responsible for insulin resistance, so it increases the blood sugar level. But in Addison's disease, the cortisol levels are reduced, so it will lead to hypoglycemia. So we have to treat the hypoglycemia, and for that we have to give 50 ml of 50% dextrose. It is important, please remember it. For hypoglycemia, we have to give 50 ml of 50% dextrose. So I told you that there is an autoimmune destruction of the adrenal gland, so there will be an antibody also. So this antibody is anti-21 hydroxylase antibody. It is very important, and it is very much likely they will ask you about this in an exam. Another thing you have to remember is the clinical features of Addison's disease. I told you there will be hypotension, hyponatremia, hyperkalemia, and hypoglycemia. So this hypotension can either be the postural hypotension, and please remember bronze pigmentation of the skin. Bronze pigmentation of the skin. Weight loss is also there, okay? So next thing they can ask you is about a patient having any cancer, example a lung cancer, is having clinical features of Addison's disease, okay? Please remember, if the cancer has been metastasized to the adrenal gland, it can lead to Addison's disease due to metastasis, okay? Okay, so next question they can ask you about a patient having a clinical features of TB like fever, night sweats, and weight loss, plus clinical features of Addison's disease. The diagnosis will be adrenal TB, okay? Another question they can ask you about an HIV patient with cytomegalovirus infection with clinical features of Addison's disease, same like hypotension, hyponatremia, hyperkalemia, lethargy, hypoglycemia. So the diagnosis will be CMV adrenalitis, okay? Both these conditions occur in immunocompromised patients, okay? Another question they can ask you is about the patient with a history of travel to USA. So there will be an histoplasma infection history. So histoplasma can also lead to hypoadrenalism. So I told you about 3 infectious causes of hypoadrenalism. First is tuberculosis, second is CMV adrenalitis, third is histoplasma infection, okay? Another question they can ask you about a female who's having recurrent pregnancy losses like antiphospholipid antibody syndrome. You have heard about it, okay? So antiphospholipid antibody syndrome is a hypercoagulable state, okay? In hypercoagulable state, what happens, there will be adrenal vein thrombosis, and this adrenal vein thrombosis due to antiphospholipid antibody syndrome is called Hughes syndrome. What is called Hughes syndrome, okay? It is also an important question. So another question they can ask you is about a patient is having clinical features of meningitis like fever, headache, neck rigidity, so and is having adrenal gland hemorrhage. What is diagnosis, okay? Bilateral adrenal gland hemorrhage. Or they can give you a clinical features of hypoadrenalism. It is Waterhouse-Friderichsen syndromes. So please remember 2 syndromes. One is Hughes syndrome, that is associated with antiphospholipid antibody syndrome. Another is Waterhouse-Friderichsen syndrome, that is associated with Neisseria meningitis infection. So now how will you investigate a patient coming to you with Addison's disease? So you will do a short synectin test. What we do in short synectin test, we take a synthetic ACTH. So this synthetic ACTH will stimulate the adrenal gland normally, okay? But we know in Addison's disease there is autoimmune destruction of the adrenal gland, so this adrenal gland will not get stimulated, so there will be no production of the cortisol from the adrenal gland, so the level of the cortisol will be less than 550 nanomoles, okay? So it is a diagnosis of Addison's disease. Another thing we can do is we can check the antibodies, that is anti-21 hydroxylase antibody. Anti-21 hydroxylase antibody we can see. Okay, so please, now I have made 3 tables that are very important for your exam. So in these tables, I have summarized some important concepts that are repeatedly asked in MRCP. First is a patient having Addison's disease and having a peripheral blood finding of macrocytic anemia and increased mean corpuscle volume. Please remember the diagnosis pernicious anemia due to reduced intrinsic factor Castle. So there will be vitamin B12 deficiency. What happens in pernicious anemia? There is reduced intrinsic factor of Castle, so the vitamin B12 cannot be absorbed in the terminal ileum. So it is a important cause. So it is important, a patient having Addison's disease with peripheral blood finding of macrocytic anemia, it is pernicious anemia, because pernicious anemia is also an autoimmune disease. So one autoimmune disease associated with another autoimmune disease, okay? Another concept is a patient with Addison's disease comes to you with complaints of hypothyroidism or Hashimoto thyroiditis, clinical features of hypothyroidism, okay? So they will ask you what will you treat first, Addison's disease or Hashimoto thyroiditis or hypothyroidism. Please remember, always treat Addison's disease first by giving hydrocortisone, okay? Why? Because if you give thyroxine, if you will treat hypothyroidism first, so you give thyroxine, okay? This thyroxine will increase the BMR. So this increased BMR will lead to reduced sugar levels, and you know already in Addison's disease the sugar levels are already low, so it will lead to severe hypoglycemia. So please first treat the Addison's disease, then treat the hypothyroidism. So these 2 conditions are autoimmune association of Addison's disease. One is pernicious anemia, other is Hashimoto thyroiditis. Another concept is the clinical features of Addison's disease, that is 5 hypotension, hypoglycemia, hyponatremia, and hypoaldosterone, that is reduced aldosterone, and 2 hyper, The most important is hyperkalemia. Okay, so this hyperkalemia and increased renin. Okay, and please remember metabolic acidosis also. Metabolic acidosis also. So any patient coming to you with hypotension, postural hypotension, hypoglycemia, hyponatremia, but increased potassium level, that is hyperkalemia, the diagnosis Addison's disease. Okay, the diagnosis Addison's disease. Okay, so thank you. I'll see you in the next class. Okay.